Thank you. So this will be a case-based discussion of a very rare neurogenetic syndrome. But despite being rare, I think this case has some important learning points which can be applied more broadly within the practice of neurology. So I'm going to start with the case of patient B, who is a 32-year-old female. And I'm going to start at the very beginning of her life by talking about her antenatal and neonatal history. So even in the antenatal period, patient B had some complications. From 6 months of gestation, there was reduced fetal growth and reduced fetal movements. After birth, there were poor APGAR scores, and there was a persistently low oxygen saturation, which led to an admission into neonatal intensive care. It was also noticed that patient B's head was quite large compared to the rest of her body, and her mother described her as being a floppy baby, what we might refer to as hypotonia. In her later childhood, there was perhaps some developmental delay, so walking was a little late, but not too late. But she began talking at the expected age. At around 18 months of age, however, she started having some seizures. These began as what her mother described as gazing episodes or absent seizures. But around the age of 3, she started to have tonic-clonic seizures, and these persisted until around the age of 5. Although the tonic-clonic seizures stopped around the age of 5, her absent seizures continued. And despite trying many different anti-epileptic drugs, none of them were able to adequately control her symptoms. In the present day, she continues to have absent seizures around 1 to 2 per week. And there is an intellectual disability. She has an IQ of 69 with an estimated mental age of around 14 to 15 years old. And she also has a range of psychiatric diagnoses, including autism spectrum disorder, ADHD, and anxiety and depression. So I'm going to invite people watching the presentation to have a think about what we might consider as an underlying cause of her symptoms, and to have a think about what investigations might help us in getting to the bottom of what's going on in this case. And I'd also invite people to think about if your answers might change if I introduce the fact that patient B also has a younger brother I'm going to refer to as patient M, whose history has quite a lot of similarities to patient B. So again, if we go back to patient M's antenatal and neonatal history, there were some complications in the antenatal period. There was a premature rupture of membranes at 37 weeks, and this led to the loss of almost all of the amniotic fluid by the time he was delivered at 38 weeks. He did have jaundice in the neonatal period, which required phototherapy, but otherwise there were no abnormalities at birth for patient M. In later childhood, neurodevelopment began quite normally, with walking and talking beginning at the expected ages, but there was a regression in his speech at 14 months, which led to him stopping talking, and this persisted until about the age of 5 or 6 years. Patient M also started having seizures. These began around the same time that the speech regression started at 14 months old. They began as tonic-clonic seizures. Now, these resolved at 7 years old, but patient M started having myoclonic seizures around the age of 11 or 12 years. And like his sister, his seizures never showed any response to anti-epileptic drugs. And for patient M, if we come to the present day, he continues to have myoclonic seizures. They're quite frequent, usually at least once per day, but up to 3 times per day. They last 2 to 3 seconds. There's no post-ictal symptoms, and he is aware when he's had one of these episodes. There is also an intellectual disability for patient M. It's a little more severe than for his sister. He has an IQ of 53, and his estimated mental age is 10 years old. He also has psychiatric diagnoses similar to his sister of autism spectrum disorder and ADHD. So going back to these questions, in possession of all of this information, I'd invite people watching to think about whether your answers to these questions might have changed. Now, if we talk about some of the investigations that were done, I'm sure many of us were thinking about we might want to do an MRI scan of the brain, but this was normal for both siblings. It didn't identify any underlying anatomical problems. Given the history of seizures, we may have been thinking about doing an EEG, but again, this was normal for both siblings. So these investigations didn't really help in getting to a diagnosis in this case. The definitive diagnosis in this case came largely by coincidence. The mother of these two patients came across an offer for a free genetic test by the company Probably Genetic. Both of our patients qualified for the test, and this was a saliva-based genetic test. And this test revealed that both of our patients were homozygous for mutations in the KPTN gene. This is found on chromosome 19. It codes for captin, which is an actin-binding protein, and this led to a diagnosis of KPTN-related disorder. So if we briefly think about some epidemiology of this genetic disease, it's extremely rare, and it's estimated that probably only around 70 people in the world are affected by this. The mutation frequency is higher in the Amish population. The family of our two patients are not Amish, but their mother did say that both the mother and father do have German ancestry. Something important to think about in cases of rare diseases is whether consanguinity might be present, but in this case, the parents of our patients are not related. In terms of some more genetic information, it's an autosomal recessive disorder. Our two patients would be most accurately described as compound heterozygotes, and I've tried to illustrate this in this diagram on the right. They do have a mutation in both copies of KPTN, in both alleles, although the mutation within each allele is different. But this has the effect of being homozygous for the mutation and still leads to the disease phenotype. The mutation that our patients inherited from their father is a point mutation in one of the exons, and this had been previously identified in other patients with KPTN-related disorder. The mutation inherited from the mother is quite interesting. It's a mutation within an intron of KPTN, and this hadn't been previously identified in other patients with KPTN-related disorder. So, in other words, the genetic studies on these patients identified a novel genetic mutation. I've just illustrated this in this diagram from a paper I've cited at the bottom. So this is a diagram of the KPTN gene, which indicates all of the mutations that have been identified so far in patients with this disorder. So this first circle indicates the mutation inherited from the father, which has previously been characterized. And I've added here the location of the mutation from the mother, which was a novel genetic mutation. The genetics in our particular case is particularly interesting. And to help illustrate this, I've constructed this family pedigree. So at the bottom, we have our two patients, patient B and patient M, and they are affected by KPTN-related disorder. But what's interesting is that on the maternal side of the family, there are several family members who don't have the full KPTN-related disorder, but do have myoclonic seizures. And so these are indicated by the patients with the hatch markings on this diagram. So we see the patient's mother has these myoclonic seizures. She has a twin sister, and they are identical twins. So we can assume that she's genetically identical to the patient's mother, and she also has myoclonic seizures. The niece of the patient's mother has myoclonic seizures, as well as the maternal grandmother. And interestingly, it's on the maternal side of the family where we have this new genetic mutation, which wasn't previously characterized. So it raises a possibility of whether this newly identified mutation in KPTN might it lead to some mild symptoms, myoclonic seizures, even in the heterozygous carriers. So the genetics of this case are particularly interesting, and all of this was only identified because genetic sequencing was performed. A brief note on possible pathophysiology of the mutation. In other words, what's this mutation doing? So KPTN forms part of a complex called Kickstall, which regulates the mTOR signaling pathway. So mTOR being a master regulator of cell growth, proliferation, metabolism, etc. And there have been some cell-based studies on mouse and human iPSC cells where KPTN has been knocked down, and this has shown that these cells have alterations in the mTOR signaling pathway. An interesting point arising from this is that the mTOR signaling pathway is quite ubiquitous. It's certainly not restricted to the central nervous system. So it does raise a question of why does a mutation involving regulation of mTOR lead to a disease phenotype which seems to primarily affect the central nervous system? There's no good answer to that question currently, but I think it is something which is interesting to think about. In terms of symptoms which have been reported across a range of patients with KPTN-related disorder, moderate to severe intellectual disability has been found in all of them, and that is present in both of our patients. Developmental delay is present in the large majority. Psychiatric manifestations, particularly symptoms relating to autism spectrum disorder, are present in the majority of patients and are indeed present in both of the patients that I've discussed. Some less common presenting features: neonatal hypotonia present in about half of patients. And in fact, in the two patients that I've discussed, patient M did have hypotonia, but patient B did have hypotonia, but patient M did not. And then around half of patients have macrocephaly, which patient B had, and seizures, which both of our patients have. In terms of managing this disorder, there's no curative treatment for the disease, and management is largely supportive. So this could include approaches such as speech therapy if patients have a developmental speech delay. Managing seizures is an important consideration if patients have seizures, although in our case, neither of our patients did respond to any anti-epileptic drugs which were trialed. And it's also important to consider social factors, given that these patients tend to have an intellectual disability. So both of the patients that I've discussed receive at-home care, which supports their parents. The female patient, patient B, has the slightly higher mental age than her brother, and so she does have a somewhat greater level of independence than her brother. But both do require some assistance with daily living tasks such as washing, choosing appropriate clothes, preparing food, etc. So as I mentioned at the beginning, although this is a very rare neurological disorder, I think there are some learning points from this case which can be applied more broadly. So a first important point is to consider underlying genetic causes of neurological symptoms. This is especially true if, as in this case, we have similar symptoms presenting in siblings, which would raise the suspicion that perhaps there might be an underlying genetic cause. It highlights the importance of taking a thorough family history. In this case, there was quite an extensive history of myoclonic seizures on the maternal side, and so that should perhaps have further raised the suspicion that there may be an underlying genetic cause for our two patients' syndrome. And finally, I think genetic diagnosis can still be valuable even when it doesn't change the approach to management. So in this case, the identification of a KPTN mutation underlying the symptoms didn't necessarily change the management of these patients, but there are still things we've gained from having done this genetic testing. There has been an academic benefit. Sequencing in these two patients did identify a new mutation within KPTN, which hasn't been previously reported. And there's also a benefit to the patient and the family. The genetic diagnosis in this case opened up a range of resources for the parents of our patients. They've since become extremely knowledgeable about the syndrome which affects their children. And so there's certainly great value to having identified the underlying cause of this disease, even if it hasn't yielded any new treatment options. And so that finishes my presentation. These are the references which have been cited during the presentation, and that just leaves me to thank you for watching.